Hi, myself Dr. Mariam. So today let's discuss about the topic rheumatic heart disease. Coming to the definition, rheumatic heart disease is a chronic condition resulting from rheumatic fever which involves all the layers of the heart, that is pancreatitis, and it is characterized by scarring and deformity of the heart valves. It is an inflammatory disease characterized by a delayed response to an infection by group A beta hemolytic streptococci in the tonsillopharyngeal area. So rheumatic heart disease, it is a chronic condition. It is mainly caused because of the rheumatic fever. This rheumatic fever, which will affect all the layers of the heart, which leads to pancreatitis. So it can lead to the inflammation of all the three layers of the heart, that is endocardium, myocardium, and pericardium. And then it is characterized by the scarring and deformity of the heart valves. It is also an inflammatory disease which is characterized by a delayed response to an infection. So it is also caused by an infection by it is called by infection caused by a group A beta hemolytic streptococci bacteria in the tonsillopharyngeal area. So tonsillopharyngeal area basically it means the pharyngitis which is caused by the group A beta hemolytic streptococci bacteria. So this is the definition of rheumatic heart disease. So before discussing about rheumatic heart disease in further, we have to know what is rheumatic fever. So the main cause or the incidence of the rheumatic heart disease, it is mainly because of the rheumatic fever. So rheumatic fever, it is an acute immune mediated multi-system inflammatory disease that occurs a few weeks after group A beta hemolytic streptococcal infection. So, because of the infection caused by the group A beta hemolytic streptococcal infection, it causes inflammation and it is an acute immune mediated inflammatory disease. So, this is called as rheumatic fever. So, the inflammation which is happening in the rheumatic fever, which it will be caused mainly in the heart, joints, central nervous system, and skin. So, and coming to the RF, which will affect majority mainly it will affect the childhood or mainly the children's, which in the age group of 5 to 15 years of age, and it can also occur in adults also, but only the 20% of cases are proved. Next one is RF or is rheumatic fever. It will occurs in more than compared to males. It will affect more in females, and it can be worse in case of females. And the disease is seen more commonly in poor socio-economic strata of the society living in damp and overcrowded place. So when an individual or a patient who is below like poor socioeconomic status, or those who are living among in the majority of the population, like overcrowded places, or where the population is very increased, or in the areas which is like slum or dam area, so these individuals or people are more prone to or at more risk in getting rheumatic fever, and this can in turn lead to rheumatic heart disease also. Next is etiology. So, what are the etiology of rheumatic heart disease? First one is group A beta hemolytic streptococcus bacteria and rheumatic fever. So, because of the group A infection caused by group A beta hemolytic streptococcus bacteria, it can lead to rheumatic fever. And this rheumatic fever in turn leads to the inflammation of all the three layers of the heart, that is pancreatitis, and this in turn leads to rheumatic heart disease. So, these two are the etiology of rheumatic heart disease. Coming to the risk factors. So, who all are prone or more at risk of getting rheumatic heart disease? First one is poor socio-economic status. So, people who are poor and to below to low socio-economic conditions are very prone to get RHD, that is rheumatic heart disease. Overcrowding. Overcrowding, people who are living in a slum or dam area, or where there is where their population is very increased, and in such cases those individuals are more prone to get RHD. Age. As I have discussed in the previous slide, commonly RHD it's affecting in children between the age of 5 to 15 years. Coming to the climate and seasons, so it occurs more in rainy season and in cold climate. So during the rainy season and cool climate, children are more prone to get fever, so it can leads to getting rheumatic fever, and this can in turn leads to rheumatic heart disease. Upper respiratory tract infection. So a rheumatic fever, it is an outcome of the upper respiratory tract infection, which is caused by the group A beta hemolytic streptococcus bacteria. So because of the infection caused in the upper respiratory tract, that is mainly in the tonsillopharyngeal area, pharyngitis, so this can lead to rheumatic heart disease. So those who are having upper respiratory tract infection also are prone to get RST. Previous history of rheumatic fever. So individual or an patient who's having a previous history of having had a rheumatic fever before, then those people also are more prone to get RST. Genetic predisposition. RST shows familiar tendency in genetics. So those who are having the genetic predisposition also are more at risk of getting RST. Coming to the pathophysiology, so as I have mentioned, because of the infection caused by group A beta hemolytic streptococcus bacteria, that is gas bacteria, it in the tonsillopharyngeal area, so that is pharyngitis. So because of that, people or the individual may get rheumatic fever, and as we know that in rheumatic fever, it is a cross immune, there is a cross immune response, and there is, it means there is a molecular mimicry between the host and the streptococcal antigen. So the antibodies, which are the immune response which was meant to attack the bacterial antigens, in addition to that it will also attack the host antigen. So this can cause the rheumatic pancreatitis, that is the inflammation of the all three heart layers, that is endocardium, myocardium, and pericardium. So endocarditis, pericarditis, myocarditis, and endocarditis in the valves, and because of that there can be erosion of valve leaflets, so which can get healed by fibrous thickening, and there is and because of that erosion of valve leaflets, there can be a thickening of the heart valve, which can end up in the stenosis or regurgitation of the heart. So this in turn leads to rheumatic heart disease. So this is the pathophysiology of rheumatic heart disease. Coming to the clinical manifestation, so how the clinical features can be seen in case of a person who is having rheumatic heart disease. The clinical manifestations divide into two categories, that is major and minor. So coming to the major category, so carditis, so it is inflammation of the heart muscle, heart layers, that is pericarditis, myocarditis, endocarditis. This can be seen in the as a major clinical feature of feature in case of RST. Monoarthritis or polyarthritis. So monoarthritis, it is the inflammation of one joints at the time, and polyarthritis, it is the inflammation of one or five or more joints at the time. So this inflammation of the joints also can be seen as the major clinical feature of the feature in case of rheumatic heart disease. Sydenham's chorea. So Sydenham's chorea, it is a neurological disorder which is characterized by the rapid, uncoordinated, jerky movements. It will primarily affect the face, hands, and feet. So this is also one of the major clinical feature which can be seen in case of RST. Coming to the erythema marginatum. So erythema marginatum, it is a skin condition which affect the arm, trunk, and legs. So it is a non-pruritic. So there is not be pruritus, there is no itching will be present, and it is a non-pruritic macular rash. It is will be a kind of a macular rashes, and it is one of the major diagnostic criteria of the acute rheumatic fever. So in case of acute rheumatic fever also, the individual may have this skin condition called as erythema marginatum. Subcutaneous nodules. So it is a firm raised lumps that develop under the skin, and it can be a deep seated lesion in the skin located in deep dermis and subcutaneous. So under the subcutaneous and deep dermis, we can see a firm raised lumps, which it is very deep seated lesions. So this is also one of the major clinical features of RST. Coming to the minor clinical manifestation. So minor, the first one is fever. So the person will have a rheumatic fever, and because of the fever there can be weakness of the body, because of weakness of the individual. Second one is malaise, that is weight loss and anorexia. So we can see weight loss and anorexia in case of RSD patients, and arthralgia, that is a joint pain. So patient or individual may complain of joint pains in case of RST. And coming to the laboratory findings, in there can be increased ESR, increased WBC count, and increased or positive C reactive protein in case of RST. And ECG, in the ECG there can be a prolonged PR interval which can be seen in the ECG reports. So these are the minor clinical manifestation when we can see in the individual or the patient who are having RST. Next, diagnosis. So how we can diagnose RST? The first most important thing is history collection. So coming to the history collection, the first thing we have to see, which is previous history of rheumatic fever. Ask the patient. This is the important point. Ask the patient whether he had rheumatic fever, or he have a previous history of rheumatic fever. So that is an important history of the patient. Next is about the risk factors. So ask the patient or the individual about the risk factors which I have mentioned in the previous slides. That is whether he is living in an overcrowded area, or in a slum or damp area, or whether he is having or he's living under a low poor socioeconomic status, and whether he had a fever in the rainy season or a cold climate, or he have upper respiratory tract infections, and about the genetics also. Ask about these risk factors to the patient. So this is also one of the important point in the history collection. Third one is strep throat. So strep throat is mainly it is a bacterial infection that causes inflammation and pain in the throat. It is also mainly caused by the group A beta hemolytic streptococcus bacteria. So this is the three important points you have to make sure that you ask the patient during the history collection period. Coming to the physical examination. So physical examination, under that, what are the major criteria which I have mentioned in the previous slide about the carditis, monoarthritis, polyarthritis, subcutaneous nodules, Sydenham's chorea, erythema marginatum. So ask, and not only the major, even the minor also. Fever, about the fever, arthralgia, and about the weakness or the weight loss and anorexia, everything you have to see and see under the category of physical examination. So make sure you see all this physical examinations properly to the patient. Mainly you have to focus on the major criteria which I have mentioned before. Coming to the blood test, WBC count and ESR, which will be elevated, as I have mentioned before. It will be elevated in case of rheumatic heart disease. C reactive protein. So the C reactive protein also will be positive and increased in case of RST individual. And cardiac enzymes levels. So the cardiac enzymes levels also increase in case of severe carditis. So that is one of the major blood test you have to see. And anti-streptomycin O-titer. So it will be elevated in 95% of the patients within 2 months of onset. So when the patient is having a rheumatic fever, or is suffering from RHT, within the 2 months of onset also, the anti-streptomycin O-titer will be elevated in majority of the patients in this condition. Then we have to do throat culture and ECG, which will reveals no diagnosis changes, but many of the patient, that is about maybe 20% of the patient, show a prolonged PR interval in case of RST. Chest x-ray. In chest x-ray, we can see the major sign is cardiomegaly and the sign of pulmonary venous congestions. These can be seen in the chest x-ray of the RST patient. Echo, we are doing to check the heart valve for if there is any damage or infection, assessing if there is a heart failure. So we can examine the heart damage of any heart valve, and if there is a heart failure, we can see through echo. And this is the most useful test for finding out if rheumatic heart disease is present. So these are the diagnosis which will help us to rule out whether the patient is having rheumatoid heart disease. Coming to the medical management. So Medical management, the first most important thing is strict bed rest. So ask the patient to have bed rest, because complete bed rest for at least 15 days. And if carditis, that is inflammation of the three of the pericardium, myocardium, endocardium, then bed rest for 4 to 6 weeks should be taken till it get settled. So the complete bed rest is very important. And salicylates, so salicylates example, we can prescribe aspirin for the patient. So for example, tab dispirin, so 1 to 2 tds for 2 weeks, that is 100 mg per kg per day. So this can also be prescribed in case of rheumatic heart disease. And coming to the antibiotics, so antibiotics, penicillin is the most important thing. 1.2 million units of benzathine penicillin intramuscularly once, or procaine penicillin 6 lakh units intramuscularly daily for 10 days. So this can be prescribed for medically managing the rheumatic heart disease. And if the patient is allergic to penicillin, then we can prescribe erythromycin. Next is the tab erythromycin, that is to tab erythromycin 250 mg for 10 days can be prescribed. So coming to corticosteroids mainly given to treat carditis, especially if the heart failure is evident. So if a carditis develop, the most important thing you can do is refer to a cardiologist. And yeah, then the if heart failure develops, treatment including ace inhibitors, beta blockers, and diuretic is very effective. Example, tab lasix half od till edema subsides. Tab lanoxin 1 tds for 3 days, so it's a loading dose. Then daily one for 6 days per week. So this can be prescribed in case of RST. And the one more thing is, you have to see whenever you are prescribing any medicines, especially in the carditis cases, so you have to refer to a cardiologist. So make sure you follow that. And ask the cardiologist opinions, and refer to a cardiologist to evaluate whether it needs any surgery or not. So the cases which we can medically manage, we can manage it. But if there will be cases which we cannot manage medically, so we can do we can refer to a cardiologist to make sure that whether to evaluate that whether we needs a surgery or not. Next one is surgical management. So when the heart failure persists or worsen after even after medical therapy or medical management, then surgery is advised to decrease valve insufficiency. Maybe it will be a life-saving method also. So 40% of patient with RHD, rheumatic heart disease, develop mitral stenosis as adult. So in these cases, surgical management is prescribed. So whenever any surgery is done or any infection develops, the main thing, we have to give a penicillin or cephalosporin cover. So injection cefaxone 1 gram IV 8 hourly for 3 days can be given. So surgical management, first one is commissurotomy, mitral valvulotomy, percutaneous balloon valvuloplasty, mitral valve replacement. So these are the surgical management which we can do in case of rheumatic heart disease. And coming to the complication. So before complication, I would like to add one more thing. Suspect rheumatic heart disease in every child with fever and joint pains or chest pain or murmur. So this is one of the important point. And once the rheumatic fever is diagnosed, the doctor or the relatives and the patient, everyone should know and remember to give penicillin cover for infections and surgical procedures. So these are the two important points I have to add on this. And next one is complication. So heart failure, first one, it can occur from either a narrowed or leaking heart valve. So because of the narrowed or leaking heart valve, there can be heart failure also. Next is bacterial endocarditis. So Bacterial endocarditis, it is mainly caused because of the infection of the inner lining of the heart. Occur when rheumatic fever has damaged the heart valve. So when the rheumatic, as I have mentioned in the definition, rheumatic fever which will get involved in all the heart layers. So when the rheumatic fever has damaged the heart valve, there can be infection in the inner lining of the heart, and because of that there can be bacterial endocarditis. Ruptured heart valve. Ruptured heart valve, it is a medical emergency. It must be treated with surgery replacement or fix the heart valve. So when the it's a my major condition, so chronic condition, so when the heart valve is ruptured, so it will be it can be treated only with surgery, that is valve replacement, or we can fix the heart valve. The valve repair can be done in these cases. And coming to the differential diagnosis, valvular heart disease, myocarditis, congestive heart failure. So these are the three differential diagnoses of the rheumatic heart disease. So this comes to an end of our topic, rheumatic heart disease. Thank you.